Thank you, Dane. It's a pleasure to be here this morning. So today we're going to touch on a really exciting topic in GU oncology, something that is old and new, as you'll see, and that's cancer immunotherapy. And when we think about the broad immunotherapeutic approaches that we use in cancer in general, it's induction of an anti-tumor immune response, such as a vaccine, a modulation of the host tumor-directed immune response, which is what the latest checkpoint inhibitors have been doing and really are where the advances are being made. And then I'm sure you're aware of some of the approaches to use anti-tumor immune effector cells, such as CAR T cells, which hasn't really made it that much into GU cancers, but there are some early studies going on. But when you think of immunotherapy in genitourinary malignancies, we've actually been doing it for a long time. When I first started, way back in the 1980s, interferon, interleukin-2, even at a time there, we used LAC cells, in kidney cancer was tried. And bladder cancer, we've been using BCG for, well over 20 years. And how does that work? It's really unknown, but it's felt that it involves activation of T cells and macrophages in the bladder. And more recently, there's been a lot of approaches for vaccines because of PSA and the ability to have a marker before there's visible disease to use vaccines in prostate cancer. And as you all know, Sipuleucel T is approved. So we actually have 3 FDA-approved immune therapies in GU cancers. Now, how does this all work? Well, basically, when you have a tumor cell with its tumor-associated antigens, it activates dendritic cells and it activates T helper cells and T4 and T8 cells, which goes after the cancer cell to try, which it recognizes as a foreign cell and tries to reject it. But the malignant cell itself, to combat actually what you could think of almost like tumor rejection, releases a number of cytokines, which activates other cells and activates other cytokines, which suppresses the immune response. So you have this yin and yang between the ability to reject the tumor cells and the tumor cells' ability to not be rejected and continue to grow. And another way of looking at this is you have your tumor cell, and there's expression of these peptides by MHC groups, which activates T cells with a T cell receptor. The activated T cell will upregulate checkpoint inhibitors such as PD-1 or CTLA-4 to temper the immune response. And then there's activation and secretion of interferon gamma, which activates the ligand of PD-1, which is PD-L1, which is then expressed not only on tumor cells, but also on activated T cells. So you have, again, this automated suppression so you don't overdo your immune response. So the way that we're trying to attack this over the last few years, as many of you I'm sure are aware, because it's been approved in melanoma and recently in lung cancer, is that to somehow interrupt this interaction between PD-L1 and PD-1 by using what we are known as checkpoint inhibitors and to therefore tamper this immune response and hopefully lead to the ability to allow the activated T cells then to attack the tumor and reject the tumor. Now, a study was done looking at, and there's been a lot of studies, but so they looking at what is PD-L1 actually expressed in different malignancies as shown here. And you can see that both in bladder cancer and renal cancer, there's about a quarter of cases in this immunohistochemistry study, it showed PD-L1 expression on the immune cells. So the IC there stands for immune cells, less so on the tumor cells. So again, you have this immune infiltrate that's coming in to attack the cancer cells. However, there's an upregulation of PD-L1, which may affect the ability of the activated T cells to actually attack and kill the cancer. So let's talk about bladder cancer, which is where there's a lot of really exciting work going on. So when we think about bladder cancer, the first thing, again, is just looking at, excuse me, is there a pointer? I can't see. Is there maybe this? Oh, here it is. I'm sorry. I was trying to find the pointer. Okay, great. So in bladder cancer, you can see this is a immunohistochemistry of PD-L1 expression in bladder cells. And you can see it's highly expressed in urothelial cancers. And in this chart over here, you can see, again, this is in the x-axis, this is PD-L1 expression. This is stage of different types of cancers, bladder cancers, and you get more invasive bladder cancer, you see the number of tumors that express levels of PD-L1 goes up. Also, there's another checkpoint or another antigen that's expressed that has previously been shown. This is involved, again, in immune surveillance and immune response. Tumors that are B7H1 negative tend to have a better prognosis than tumors that are B7H1 positive. And this is also involved in the autoregulatory effect of this pathway. So therefore, you can see that there seems to be increased expression of PD-L1, which should give us a good rationale to use this approach in bladder cancer. MPD-L3280A, which I'll just call MPD, many of you may have heard about. It's a human anti-PD-L1 IgG1 monoclonal antibody that blocks PD-L1 to PD-1, and it also blocks its binding to B7-1 on activated T cells. So as you can see here, it interferes with this ability of the tumor cell and the immune cell to let PD-1 and PD-L1 bind to each other, and at the same time will not allow the binding to a second, the PD-L2 antigen, which will again allow not an increase in the amount of immune side effects. So this is actually a very good antibody to use in this setting in clinical trials. And so there was a large study, a phase 1 study, which was expanded over and it's been published already. Many of you have seen it. It's published in Science, looking at PD-L1 in a large array of different tumors. And we're just going to go over the bladder cancer data. This, you can see here, these were patients. It's about 65, 70 patients were studied. In all the patients, there was immunostaining for the PD-L1 in the tumors to see if there was any sort of correlation. And here you can see the list of PD-L1 positive and PD-L1 negative tumors, 65 patients total. And this is just different urothelial cancers. Most of them are metastatic, and most of them had had prior platinum therapy. This gives you an example of one patient who had a complete response in the lungs. A patient, again, who had been treated with gemcitabine and cisplatin. This patient did relapse after a 4-month treatment interval, and her tumor was PD-L1 positive. I think this is a really interesting slide, which gives you an array of looking at response as a waterfall plot, and the colors represent the amount of staining of the PD-L1 in the tumor specimens. And you can see it goes from red, which is 0, down to dark light green, which is 3. And there is a trend towards patients with higher expression of PD-L1 having a more robust response, but it's not absolute. I mean, it doesn't totally correlate, but there is a suggestion. More interesting is actually the duration of response. So even patients who seem to respond for a long time, something we see in a number of these immunotherapies. And 19 of 22 responding patients had ongoing responses at the time of data cutoff, with the median having not yet been reached. And you can see here, the red dot is when they've been discontinued, but many of these patients remained on therapy when this was reported. The toxicity was moderate at best. The biggest major toxicity is fatigue. Some people do get an immune response, immune reaction when they first get the drug, but it's generally well tolerated. There was no grade 5 AEs, and really was a drug that seems to be well tolerated by our patients even after platinum, which some of the patients can be pretty well beat up. When we looked at overall response rate in bladder cancer related to the actual immunohistochemistry staining, you can see again there was a trend towards if you had more PD-L1 in your tumor, you were more likely to respond, 52% in IHC 2 and 3 versus IHC 0 and 1, and all the CRs had at least IHC 2. And I guess what's even more impressive is the median progression-free survival was almost 3 times as long in patients who had higher expression of PD-L1. So this is a very exciting result from this cohort of patients with bladder cancer, and this drug has received fast-track approval for this indication because of these early phase studies. So in summary, there was a very high response rate, 52%, mostly patients who already gotten platinum and mostly patients whose tumors expressed PD-L1. though we did see 14% of patients respond who had no or little expression of the PD-L1 protein. Many of the patients continue to be on trial when the data was cut off. It's well tolerated. And listed here are additional studies that are going on using this antibody. One study, a phase 2 single arm of PD-L1 patients with locally advanced bladder cancer, either second line or platinum ineligible, I believe is closed already. But that once these studies open, as you can imagine, they close quite quickly as patients want to get on them. And there will be a phase 3 trial, which will probably be a registration trial of this drug in the second line for patients who've progressed on platinum. The other interesting drug is a drug that targets not PD-L1, but actually the PD-1, and this is MK-3475, also known as Promalizumab, which I'll just call Pembro. Many of you may be familiar with this drug, this antibody. Again, it works similarly by going after PD-1 instead of PD-L1. There's been a number of trials out there with this drug. In the urothelial cohort of the Keynote-12 study, which was, again, recurrent urothelial cancer. Patients had received prior treatment. They were randomized. They were treated with 10 milligrams per kilogram IV every 2 weeks. And this was a study, a discontinuation study. If you progressed, you went off. If you had a CR, you went off. You could go off or continue. But most of the patients were interested in those in the middle that were stable or a partial response, and then they continued on trial. This is the baseline characteristics. Again, this is a cohort of a larger study, so it was only 33 patients. You can see here, mostly good patients. About 20% had liver metastases, and most of them, almost all of them, had prior treatment. In this waterfall plot, it's demonstrated the responses. Again, a large number of patients, 64% of patients experienced at least a decrease in their target lesion. And in immune therapy, that's generally felt to be good, even if it's not a 30% decrease. And again, we're seeing that there's a number of patients continue on study. And for those of us who have treated patients with these immunotherapies, I think that's the exciting thing, is patients will achieve a stable PR that goes on for even years. And the median follow-up of this study was 11 months, and 21% remained on therapy. Another interesting thing I want to point out is a lot of these patients respond generally quickly who go on these immunotherapies. They're not responding 6 months later. Sometimes they respond as soon as 4 weeks, which is something you should know when you start using them, that you can actually see the response quickly. In terms of toxicity, this is a little more toxic than MPD, a little more immune side effects, edema, fatigue. Sometimes there's some liver toxicity, concerns about autoimmune type hepatitis and other autoimmune problems. So this one is something that you have to keep a little closer eye on in terms of what you're worried about. But another interesting thing in this study is they saw a partial response in patients with liver metastases, which, as we all know, is generally the cause of death in patients with bladder cancer. So this study was generally, it was a good study, well tolerated. The response rate was around 24%, not as robust as the MPD study. In this study, I'm neglected to mention, you had to have only 1% of your immunostaining of your tumor cells, immune cells, had to have expression. And the Keynote-45, which is the follow-up study, is a study versus chemotherapy in patients with advanced bladder cancer. Now, recently at GU ASCO, Andrea Apollo gave a great review of comparing these studies. I'm not going to go over this slide, but you will be able to have access to it, and I think it really summarizes everything. She also showed where are the new trials coming in checkpoint inhibitors, and this just gives you little states, the states of bladder cancer. And you can see here there's many different trials coming in cisplatin ineligible, cisplatin refractory, early stage, with these drugs and some other drugs alone and in combination, and there's going to be development for all stages, neoadjuvant and adjuvant. So I think there's going to be a lot of opportunity for clinical trials in bladder cancer. Combination immunotherapy trials, chemotherapy trials, and I just wanted to mention a completed trial, which is also an immunotherapy, which is going on the Sipuleucel T type backbone approach, which is a randomized HER2-directed immunotherapy trial in patients who are at high risk for relapse. That was a randomized phase 2 trial. That's completed, and we'll probably hear about that in a year or two. Now, in kidney cancer, the hot drug is Nivolumab, which again in a phase 1 trial showed response rates of 29% with a PFS of 7 months. Bob Motzer conducted a randomized phase 3 trial with which we participated in. We had 3 different doses. You can see the number of patients that went on this trial. The progression-free survival was about 4 months in this cohort. It didn't really seem to matter by dose of drug. And again, there was no real DLT in this trial, so patients tolerated it very well. But again, what's interesting is here in this waterfall plot, you can see the response rates were also similar in all 3 dose cohorts, occasional CRs, PRs running about 20%. So very exciting in this initial study, and as we're seeing in bladder cancer, many of the responses continue for quite some time, going out, even 2 years. And I personally have had patients go beyond 2 years on getting this drug. Well tolerated. The biggest side effect is pulmonary side effect, which can be worrisome and may cause you to stop the drug. There was also at this time in this study a second trial done by Tony Chowdhury and Dana-Farber where he was doing biopsies on patients getting 4 doses of this drug. I'm not going to go into the detail of what he found, but just to tell you that, again, you saw a vigorous response rate, 9 to 20% at different dose levels. And as we saw before, mostly patients who responded had PD-L1 expression, though some responded without, but in this, even more so than in what we saw in bladder cancer, there was no true correlation. This was not a biomarker of response to this drug. There's been a number of other renal cancer studies using Nivolumab, a combination with pazopanib and sunitinib with the VEGF inhibitors. There's one with Avastin, which looks promising, had a 40% response rate in about only 10 patients in the combination. There's also other drugs looking at PD-L1 inhibition, smaller studies. You can see, so there is activity in kidney cancer, and these are some of the phase 3 trials. The first one has been completed. That was, again, a registration trial in the second line where everolimus is FDA approved, so it's a phase 3 trial comparing Nivolumab to everolimus, and we should hear about that soon. We'll see whether this results in this being approved. And then there's some of the other ongoing studies, which are mostly randomized, including bevacizumab in combination. This is a 3-arm study. Nivo plus Bev versus Nivo plus Ipi. And then here's another study of Nivo with Ipi versus sunitinib. So you can see there's a lot of things going on in this space in kidney cancer, and I'm sure in the near future you'll be able to use this in your office. Now, prostate cancer is an area where most of you are familiar with, especially with Sipuleucel T, and because there's only 20 minutes to talk about this, I wasn't going to spend any time really discussing this. I'm sure many of you use this in your practice. GVAX was another similar GM-CSF transfused prostate cancer cell vaccine approach that failed. The phase 3 trial was closed for futility, but ProsVac is one that is interesting and is now in phase 3. And there's a double-blind phase 3 trial of ProsVac, which is PSA Tricom. It's, again, without going into details, it uses a approach of 3 antigens. The initial injection is a vaccinia-based approach, and then the maintenance over months is a Fowlpox-based approach because of your body developing an immune response to the vaccinia. And this is it's randomized in 3 arms, drug alone, drug plus GM-CSF, and placebo. And there's a lot of enthusiasm about this trial just because of the phase 3 studies in Sipuleucel T, which showed about a 4-month progression survival advantage, rather. You can ProsVac early trials, which were smaller in this randomized phase 2, and in a phase 2 single arm, you can see that it was 8 months. So this is being pushed. This is still accruing patients. CTLA-4 inhibition, which is widely used in melanoma, is also been studied in prostate cancer. You may be familiar with a phase 3 study in the post-Docetaxel space, so patients who are metastatic castrate-resistant who've gotten Docetaxel. This was a negative study in terms of survival. It was 11 months versus 10.2 months. But the interesting thing is when they did subgroup analysis and looked at patients with visceral metastases versus no visceral metastases, and again, this is blue is no visceral metastases getting Ipi, the orange is no visceral metastases placebo, and then the other two are with visceral metastases where you can see with or without Ipi there was no difference. It seemed that there was a improvement in survival over here. So based on that, there was a chemo-naive study, the pre-docetaxel space, excluding the visceral metastases. That has been completed, but we're waiting for the results on that. So it's possible this drug will make it to market in the future in that space. So finally, just some of the questions and thoughts to leave you with. Should we use PD-L1 status to select patients for checkpoint inhibitor therapy? I think the verdict is out on that. Certainly in bladder cancer, it's a little more encouraging that this may be a marker. And the question is, do we look at the tumor cells themselves, or do we look at the immune infiltrating cells? Most of the studies seem that infiltrating cells may be a better marker of predicting response. But one of the more intriguing questions is actually, can we change PD-L1 status? So interferon, we know, upregulates PD-L1. Can we give a drug or like interferon or something else, increase PD-L1 in the tumor cells so you get an infiltrate of tumor cells, and then add a checkpoint inhibitor and see if you get a tumor response? What other markers can be used to assess response to checkpoint inhibitors and help us guide our therapy? And finally, since we are oncologists, the one thing we always like to do is combine therapies. So what's the best combination therapy? Is it a combination of immune therapies like we're seeing in melanoma? Is it with chemotherapy? And what other strategies should we use? So with that, I'll stop, and thank you.
Whichever you choose.